Okay, I'll start recording also. Okay,
Hi, everyone. I see people slowly starting to join. Thank you so much for joining our third session in our age-friendly geriatrics education tele-echo series, Enhancing Your Client's Health Check. Let's see. And today's topic is going to be focusing on changes in condition, dementia, and stroke. And this session is going to be recorded, so a link will be sent to you early next week, and you're welcome to share with your colleagues if needed. This is the structure of our session today. We're going to go ahead and start with our welcome introductions and announcements, and then followed by a quick 30-minute didactic, and then we're going to go ahead and move on into our case presentation and collaborative discussion, followed by closing and reminders. As house rules, please just make sure you mute yourself when you're not speaking to prevent any background noise. We're going to go ahead and introduce ourselves, but anytime you want to speak up for the case discussion, please go ahead and introduce yourself. And then always maintain confidentiality when speaking about your client. And then, of course, respect others and their opinions. This series is approved by the California Board of Registered Nursing, so you will receive CE certificate at the end of the series with the total number of CEs you have received in the series. Please be sure to complete the form sent to you in the follow-up email if you would like to receive CE credits. Certificates can be submitted to your own licensing for rest process and the CEs as transferable. You are going to have to attend the full hour if you would like to receive credit. Our series is a part of the HRSA Geriatric Workforce Enhancement Grant at UCI, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. Again, we truly thank you all for attending today's session, and we're going to go ahead and move on to our introductions. I'll go ahead and get started. My name is Nika Seville. I'm a grant supervisor at UCI Health in Orange. And if you are on the line today, can you please make sure that you put in your name, role, site, and location in the chat? And then we'll go ahead and have our hub team introduce themselves. Dr. Sagel.
Hey everybody, welcome. It's my pleasure to be with you today. I'm Sonia Sagel. I'm a geriatrician and clinical professor in internal medicine and geriatrics at UC Irvine.
And thank you, Dr. Sagel. And Geraldine? Geraldine, I think you're on mute.
Hi, everybody. Nice to see you guys. My name is Geraldine. I'm a licensed clinical social worker in the Senior Health Center in the UCI practice here. And happy Friday.
Thank you, Geraldine. And Carlos?
Good afternoon, everyone. My name is Carlos Garcia, and I'm the data analyst for our Geriatric Workforce Enhancement Program. Welcome.
Thank you. I think a few members of our hub team might be joining us later on today. Okay, and we'll go ahead and move on into our didactic presentation, focusing on changes in condition on dementia and stroke, presented by Dr. Sagel. Please remember, if you have any questions along the way, feel free to raise your hand or post them using the chat function, or you can save them until the end of the didactic. Dr. Sagel, you can go ahead.
Thank you so very much. It's my pleasure to talk with you today about dementia and stroke. And as Nika mentioned, please don't hesitate to let me know if you have questions, would like to share a story about a patient or a client that you've worked with who has dementia or stroke. So please, I'd like this to be as interactive as we can make it in the time that we're together. So again, we're going to talk about dementia and stroke, and we'll start off by talking about dementia. I'll start off with a case, and we'll talk quickly about what dementia is and how we define it and how we manage it. And we'll talk a little bit about how to think through dementia behaviors. And then we'll follow that up with a brief discussion about stroke. We'll talk about stroke symptoms and the different kinds of stroke that people experience. And we'll talk about things that you can consider and do if you are ever presented in a situation where you feel a patient is having an acute event. And then very briefly, we'll talk about stroke sequela and really why we want to act quickly if someone is having an acute event so that we can prevent complications that occur. Next slide. So let's talk about a brief case. And again, we're going to start off by talking about cognitive impairment or dementia. So here we have a client. This is Ms. Lee. And you know Miss Lee, and you've known her for quite some time. You knock at the door as you're dropping off meals, and she appears confused. You've asked her today how she's doing, and she's confused about who you are. And previously, she would have known you and your name. She refuses the meals that you present and says that she has plenty of food in the fridge and that she did not place an order for anything today. You notice that her shirt is not buttoned, that she looks disheveled and dirty, and that her shoes are on the wrong feet. And this is someone who, in months past, usually was well-dressed and took pride in her appearance. So let's talk a little bit about what's going on with Miss Lee. Does anyone have any thoughts or considerations for how you might approach her? And I suspect that as things open up and we start to certainly see more patients in the office who've been isolated, and as people are able to go out and meet clients in the field, we might come across people that we've known for many, many months, like Miss Lee, who've had a change in their cognition and a marked change in their behavior. So when approaching Miss Lee, does anyone have any thoughts about what questions you might ask her or ask yourself in evaluating her situation? Would anyone like to share? So we have a question in the chat from Geraldine. So the question is anyone with her and know she's alone? Nika, we can go on to the next slide. Thank you. So some considerations that I might ask would be, is this a new behavior or is it worsening? So if you have a relationship with Ms. Lee, or if you've known her in the past, did she ever exhibit any confusion before? Did she ever have trouble recognizing you or any of your colleagues in the past? You might ask her if she knows who she is. So does she know her name? Does she know the date? And then you might peek in through the door. So does her house, if she'll let you in, or if not, maybe just kind of peek behind the door. Does it look cluttered? Is it messy? Is it unsafe? And is she making sense? Is she repeating herself? And, is there evidence that she's eaten the food that you or others have brought to her? And really what I'm trying to, as I ask myself these questions and as I look and talk with Miss Lee, I'm really trying to determine whether she's safe. Is she safe to be alone? Is she safe for me to leave her and move on to my next clients or my next patients? And is there something that I need to do to ensure her safety? And as we go through and as I chat with Miss Lee, she does seem increasingly confused over the past 6 months. She doesn't know who I am. She doesn't understand why she's receiving meals. And she asks the same questions many, many times. And it appears that she's not eating adequately because it looks as though she's lost a significant amount of weight. And the reason I know this is her pants and shirt seem quite loose. Now, at the Senior Health Center where I practice with Geraldine and a few of the other hub members, we've seen situations like this in the past. We actually had a patient many years ago who forgot his groceries in the back of his car, and they had been there for many weeks and were only discovered after the smell was picked up by neighbors, and they did a little investigation. And the person had been having a decline in cognition, not eating, losing weight, and the neighbors became significantly concerned and alerted respective agencies. Next slide, Nika. So the first thing you might do is, you're going to try to assess how to communicate with her, and you all are experts at communicating with your clients, and you know how to do that. But the real consideration here is, do you call family? Do you call 911? And I think in her situation, we would all call family. And then the question is really, is the situation so severe that we would need to call Adult Protective Services if she's a danger to herself when left alone, or is there really a significant emergency that authorities needed to come out right away? And we'll talk through that in a little bit. Next slide. So I think if we take a step back and we look at this woman's symptomatology, she's having some short-term memory impairment, she's confused. There are quite a bit of things that can be in the differential diagnosis for short-term memory impairment. Certainly dementia is probably top of the list, particularly if the cognitive impairment or short-term memory has been progressive in nature, it's been going on and worsening over many months. Now, you all know that dementia is a disorder of cognition. We commonly think of it as impacting short-term memory, but there are many different forms of dementia, each with their own characteristics. Next slide. In primary care, we know that dementia often goes under-recognized. And this slide that I'm showing here, this graph shows really that the prevalence of dementia, so the percent of people in a certain population, and this population over the age of 80, approaches almost a 40% prevalence of cognitive impairment. So anytime I encounter who's in my clinical practice, I always ask myself, should I be thinking about memory impairment, even a very subtle decline in memory? The yellow bars show that the cognitive decline most often is related to a condition called Alzheimer's disease. And Alzheimer's disease is a form of dementia. Next slide. Now, the trajectory of cognition as we age goes from normal changes that occur as one gets older to a pathological condition called cognitive impairment. And then if cognitive impairment worsens, the patient develops a dementia. So there's this trajectory, and cognition is thought to change on this continuum. Let's talk a little bit about normal changes associated with aging. So I certainly experience these changes on a daily basis. They're irritating and annoying, but they're not impacting one's daily life and overall ability to function. The mild cognitive impairment state, again, is this pre-dementia condition, and it's in between normal and severe sort of cognitive limitation. Next slide. What do normal changes of aging look like when we think about cognition? So you may have experienced, I know I have, that I may forget where I put my purse or my keys, or it might take me a few seconds or even a minute to recall a specific name of a person that I don't encounter very often, or a name of a place or a very specific item, but I am able at some point to recall that information. I can find my purse eventually. I can find my keys eventually. It's annoying, it's irritating, but it's not impacting my day-to-day function. Patients who have changes consistent with normal aging don't get lost. They don't have issues with their ADLs or their IADLs. They really do function very well in life. Often these complaints are subjective. So, I might feel that my memory isn't what it used to be, but those around me, my children, my family, my colleagues, they aren't noticing a change in my productivity or in my day-to-day tasks. It's really characterized by difficulty or time associated with name retrieval. And the speed and efficiency of information processing does go down. So for example, I have patients who are 85 and 90 and they're still doing their taxes, and they get them completed. They're completed accurately, they're filed on time, but the speed in which they actually can file and process the numbers and process the data, it takes them a little bit longer, might take them a lot longer, but they are able to do it. So those are all changes that are considered normal. So slower speed and efficiency of information processing, some difficulty with recall of specific information. Next slide. If we take a moment and talk about mild cognitive impairment, so this is this intermediary state. It is pathologic, and when we say pathologic, I mean it's not normal. It's more common, but definitely not normal for aging. And this usually impacts memory, although there are other forms of mild cognitive impairment that affect other aspects of cognition. People who have mild cognitive impairment, we know that they progress to a dementing illness more often than someone who does not have this condition. And the memory deficits may be minor or severe, but the patient's able to compensate for them. And we're able to detect more cases of mild cognitive impairment through increased screening for memory deficits. I actually had a patient in my office for many, many years who was diagnosed with mild cognitive impairment. She would come to the office and see me alone. Her husband would not accompany her because she took pride in managing herself. And she couldn't, when she left my office, if she did not write everything down that we talked about, she would not be able to recall medication changes, doses, any recommendations, any follow-ups that were needed. But she was able to compensate. She had a notebook, she carried it with her everywhere she went. She wrote down everything that she needed to do, and she was able to get everything done. All the points, client with her medications, she did a great job. So this is a person who had mild cognitive impairment and was able to compensate. Next slide. Patients with dementia now have short-term, they may have very severe short-term memory impairment, but they lose the ability to compensate. It becomes harder for them to perform their day-to-day activities, and they require assistance in managing their ADLs and their IADLs. Now, you know that dementia is an umbrella term, and it's used to describe symptoms of a group of more than 100 conditions that impair memory, behaviors, and thinking. So it's an umbrella term, much like the term cancer. So there are lots of different kinds of cancer. There are lots of different kinds of dementing illnesses. And the four more common etiologies of dementia are listed here. Alzheimer's disease. So these folks, again, this is the most common form of dementia. The most prominent symptom here is short-term memory impairment. These folks have little insight often into how great their memory is impaired. They retain the ability to have conversations, and they retain their social graces, but their short-term memory is significantly impacted. There's also vascular dementia. And this type of dementia can be seen in people who have what we call vascular risk factors, or things that can impact blood flow to the brain. Stroke, for example, or diabetes, or high blood pressure, or high cholesterol. We also see Lewy body dementia, and this is a very interesting form of cognitive impairment where prominent features include visual hallucinations. So these patients, the short-term memory is not as significantly impacted, but they actually describe seeing very vivid, they have vivid descriptions of people or animals that are not there. And then there's frontotemporal dementia. And frontotemporal dementia happens in a little bit of a younger group of people, these folks can have short-term memory impairment, but the most prominent feature is disinhibition. They become impatient. They lose their sort of what I think of as social graces. They may become impatient. They may yell. They might start to use foul language. They might start to disrobe. It can be very frustrating for their family and those around them because they lose their inhibition. Next slide. So dementia is the sixth leading cause of death in late life. Again, as I mentioned, Alzheimer's disease is the most common form, and it's a neurodegenerative disorder characterized by short-term memory impairment. The trajectory of someone for Alzheimer's disease is usually, we think of about 10 years. And due to this erosion of cognitive functioning and physical ability, eventually this can lead to death. We talked about the other forms of dementia. And again, as I spoke about earlier, there are many, many different things that can cause a dementing illness: head trauma, anoxia, many, many different forms. Next slide. Now, the risk factors for dementia are what you would think. So, as we get older, our risk of dementia goes up. If we have mild cognitive impairment, our risk goes up. For folks that have vascular dementia, even Alzheimer's for that matter, if we have cardiovascular disease, hypertension, diabetes, those types of conditions do increase our risk for cognitive impairment. If we have a family history, so if grandma, grandpa, mom, dad had cognitive limitations due to a dementing illness, there is a risk as well. And then people who have very heavy alcohol use, multiple head injuries, such as football players or other head injuries, definitely are at increased risk for dementia. Next slide. I wanted to spend just a moment talking about Alzheimer's disease because it is the one that's most commonly seen. And the reason that we think Alzheimer's disease develops in part is because of these beta amyloid plaques and neurofibrillary tangles that we see on pathology. So to make the diagnosis of Alzheimer's disease, truly, we do need to see brain tissue. We would never extract that tissue in someone that's living, but postmortem show pathology. And there are many theories for why people develop Alzheimer's disease, and the difficulty in understanding the pathology and why this occurs explains some of the difficulty in developing adequate treatments. So unfortunately, this is an area in medicine where we have some medications that can impact the trajectory of cognitive impairment, but we don't have any groundbreaking, miraculous strategies as of yet that can really reverse pathology and symptoms that have already developed. Next slide. Oh, can you just hit it one more time, Mika? And one more time, thank you. So when we think of cognitive impairment, as I alluded to before, the neurodegenerative disorders like Alzheimer's or Lewy body, FTD, vascular, these are dementing conditions or dementias that are irreversible. And so once a patient exhibits a change in their cognition, unfortunately, we can't reverse that. But there are things that can happen to a patient or a client that impair cognitive functioning that might be reversible. So these are not considered dementias, but these are clinical presentations that can make someone look as though they have a significant cognitive impairment. And things on this list would be depression. So if someone's very depressed, they might start to look like they have short-term memory impairment. They may actually look like they have Alzheimer's. But in fact, if we treat the depression, we might get this person to function better. There are certain metabolic problems, alterations in calcium, in thyroid functioning, that can make someone look like they have a dementing illness when they don't. There are certain vitamin deficiencies like vitamin B12 or folic acid. Sometimes brain tumors can do this. Certainly infections in the elderly, like urinary tract infections, can make someone look like they have a significant impairment. And then medications. There are a whole host of medications that can impact one's cognition. And so we try to be very cognizant of these reversible causes so that we can really make sure that one is functioning at their best. And so for our patient that I talked about early on in this talk, considerations for her, the change in her clinical profile would be to look at all of these things and make sure that they are not occurring. And if they are, that we adequately treat them before we make a diagnosis of Alzheimer's disease or any of the other dementias. Next slide. Now, as you all know, patients who have dementia have significant problems in managing their IADLs and their ADLs. And these difficulties often clue us in, or they're hints that someone might be experiencing cognitive difficulties. So certainly if someone is having difficulty managing their bills, if they're unable to cook for themselves, or they have meals that are delivered and they're not being eaten, the food in the fridge is rotting or spoiling. Maybe they're losing weight due to this. Maybe they're not dressed appropriately. So if it's 90 degrees outside and they're wearing a sweater and woolen pants, that would be inappropriate dressing. Or if their clothes look loose, or they're not buttoned appropriately, they're asking repetitive questioning. If they're getting lost in familiar places or having difficulty recognizing known people, these would be clues and symptoms that someone is maybe experiencing a dementia. Next slide. So let's talk a little bit about behaviors. So one of the main things that we see in our clients and our patients who have a significant cognitive impairment are behavioral issues. And they're very distressing. They're distressing to the client and the patient, but they're also distressing to loved ones. And it's important to take a step back and just sort of think about, well, why is this happening? Well, this change in brain structure and brain texture and brain functioning can lead to cell death and cell change in the brain. And the way this manifests clinically can be through mood swings, loss of understanding and logic, perseveration, disinhibition, and difficult and agitated behaviors. And the most purpose for a clinician is to see families not understand these behavioral changes and not relate them to the patient's clinical disease process. So this dementia, oftentimes these behaviors are misinterpreted as that the patient is trying to be deceiving, or that they're angry, or that they willfully are acting out in a certain way, when in fact it's really the disease process that is causing these behaviors to occur. Next slide. One of the most challenging behaviors that we see in clients and patients is aggression. And this aggression can sometimes manifest as a participant or a patient becoming mean. Sometimes they can be combative. They can say hurtful things. And we think that these behaviors that they're exhibiting are due to unmet needs that they have and their inability to express what the unmet need is. So for example, in the nursing home setting, in a dementia unit, for example, if a patient's not able to communicate that they have a headache or that their knees are painful from arthritis, they may start to yell or scream or strike out. And we try to manage that through adequate pain control. Sometimes these patients can't express their sadness, their frustration, and their loneliness. And these can manifest, and this inability to display their emotions can lead to aggression. And sometimes it's fear of a new place, fear of being alone, that can lead to behaviors such as aggression. Next slide. So I think it's important to remember that just a couple things when we are faced with a client who is maybe having aggressive behaviors or slightly aggressive behaviors. I always need to remind myself and my patients of this, that it's important not to reason, confront, remind, or question so the behavior that someone's having. So I have a patient right now. She has a moderate dementia. She's very confused. She is trying to. She believes that one of her neighbors is trying to steal from her and poison her. And her family, just does not understand that this isn't her. This is her disease manifesting in this type of confusion and aggression. And they very sadly are trying to remind her, confront her, and reason with her, and it's just not working. And so I just really like to put it out there that that type of process isn't going to work for these folks. So and I know how to communicate with people who have cognitive impairment. Now, I did want to take a minute and just talk a little bit about treatment plans and medications. There are medications that can manage behaviors. There are a few drugs that are approved for Alzheimer's dementia. They're not terribly effective, and so we really do rely on family and loved ones and friends and those around these folks to be supportive and provide the necessary social and cognitive stimulation for these folks. So if we think back to our client, Ms. Lee, you decide after kind of talking with her and seeing her that she's actually not in imminent danger, so we don't need to call 911. So we decide to call her daughter, whose phone number happens to be on the refrigerator. And the daughter comes over and explains that through the pandemic, things have gotten worse over the past few months, that the client has become more confused, but they haven't been able to go into the doctor's office to get this evaluated due to the pandemic and concerns regarding COVID. But because we called the daughter, her suspicions have been validated, and she makes it a priority to have a medical evaluation done right away. And she agrees that the patient or the client should not be living on her own and just in her home while the workup is being completed. So I'm going to leave dementia there, and we can open it up to questions at the end. And I'm going to turn it over to stroke now. Next slide. All right, next slide. So with stroke, so this is Mr. Thomas, and he's an 80-year-old client who too has been alone and away, sheltered in place due to the pandemic. And we go to his door and we knock, and he says, "Who's it?" And he says this to us in an unfamiliar way, with evidence of slurred speech. And you can hear some stumbling in the background behind the door, and it takes him a very long time to get to us, and he has significant difficulty opening the door. Next slide. And I'll say, next slide. All right. So when we approach Mr. Thomas, we again want to make some sort of an assessment of what's going on. This is uncharacteristic of him from what we remember of him prior to the pandemic. We ask him if he's okay, and he says he is, and we look at him and we try to have a conversation with him, and he seems awake and he's talking to us and he's alert. But we notice that the right side of his face is drooping, and he's not able to use his right hand appropriately. So he can't lift it over his head, and he had difficulty opening the front door. And he also tells us that his right leg feels heavy. Next slide. So we immediately are thinking, oh my goodness, has this client had a stroke? And the things that I always ask myself is, did this change happen suddenly? Or has this been going on for a long time? So people who have had strokes can have weakness that persists and that will not get better. But if it's sudden, then maybe we need to take some immediate action. We might ask him if he has a headache or a severe headache. And we might want to know if he has any medical problems, because certain medical problems do cause one to have an increased risk of having a stroke. And we find out from him that his symptoms started about 1 hour ago, that he does have a terrible headache, and he's had a many-year history of diabetes, high blood pressure, but he tells us that he's had no strokes in the past. Next slide. So what should we do? How do we approach this situation? Next slide. So we have an 80-year-old man who has diabetes and high blood pressure, who 1 hour ago started to have right arm and leg weakness. He's got facial droop, and he's got some difficulty communicating because he's not speaking quite as clearly as he did before. And the most important thing is that these symptoms happened about an hour ago. Now, in this situation, we should call 911. And we want to get this gentleman to the hospital right away for an evaluation for a brain attack or a stroke. And after we call 911, we can try to contact his family. We would stay with him and make sure that he gets adequate medical support. Next slide. So let's dive into stroke a little bit more. So strokes are the 5th leading cause of death in the United States, and it is the #1 cause of serious long-term disability in the United States. About 800,000 people have a stroke every year, and 130,000, unfortunately, will succumb. And it's a very costly condition. But the most important thing to remember are that 80% of strokes are preventable. And if we can treat stroke, if we can identify stroke in a very quick manner, in a very timely way, we can actually prevent significant debility in our clients and patients. Next slide. So let's talk about what is a stroke. So it's a brain attack. We're all familiar with heart attacks. Heart attacks happen because vessels in our heart become clogged with debris or cholesterol or plaque, and that leads to a lack of blood flow to a certain part of our heart, and that's a heart attack. One is the high rate of battery, and a stroke is a brain attack. So it's something occluding the flow of blood to a part of our brain, and if that part of the brain does not receive blood, it's going to result in permanent damage. And depending on where this occlusion is happening, that will determine what functions are lost for a person. Next slide. There are 2 main kinds of stroke. One is called an ischemic stroke, and that occurs because of a clot or something, a clot or an embolism or a plaque is impeding the flow of blood. And you can see that on the cartoon that's on the left. And basically this is showing that a clot is blocking blood flow, and this gray area of brain is not receiving oxygen, it's not receiving blood, it's not receiving nutrients. And if we can't alleviate that blockage right away, that portion of brain tissue will die. The picture on the right demonstrates the hemorrhagic type stroke, and that's basically where a vessel ruptures. And because the vessel's has ruptured and blood is leaking out into an inappropriate space, there is lack of blood flow and oxygen and nutrients, also to tissue in the brain, which leads to death. Next slide. So again, the more common form of stroke is ischemic, and that's when a blood vessel is blocked for some reason. And there are certain medical conditions that if you see in a client that put them at increased risk for ischemic stroke. And atrial fibrillation, which is an irregular heart rhythm, is one of the more common causes. Next slide. And then again, there is the hemorrhagic stroke, and this is when a blood vessel ruptures. And you can see in these small CT images that there is a, in the brain tissue, there's like a very white, bright area where brain tissue should be, and that basically is showing that there's blood accumulated where it should not be. Next slide. There are several risk factors for stroke, many of which are non-modifiable that we can't do anything about, but there are some that we can. So here are some non-modifiable risk factors. So age, again, so the older we are, the more at risk we are for having a stroke. And in fact, after the age of 55, every 10 years, the stroke rate doubles in both men and women. Men do have a higher risk of having a stroke, but more women unfortunately pass away from having a stroke because women do live longer. There are certain other things like family history of stroke, folks who are African American, Native American, some Asian Americans are at higher risk for stroke. People that have kidney disease, diabetes, lupus, certain blood issues, heart issues are at risk for stroke. And then interestingly, pregnancy can be a non-modifiable risk for stroke. And that's because pregnant women are hypercoagulable. They clot more than they should, and that can lead to stroke. Next slide. So what can we modify? You know, how is it that we said 80% of strokes are preventable on a few slides back? Well, adequate treatment of hypertension. So if we can really get our clients and our patients and ourselves adequately treated for high blood pressure, we can bring our stroke risk down. This is the single most important modifiable risk factor that there is. For people that do have atrial fibrillation or an irregular heart issue, we definitely want to treat that adequately. For people that smoke or are using substances or excessive alcohol, we want to get that modified also to bring stroke risk down. Next slide. Now, I mentioned earlier that depending on which portion of the brain is affected by a clot or a bleed, that's going to really determine what symptoms a person has. So not everyone will have facial droop, or their arm or their leg might be weak. But the more common symptoms and warning signs are presented here. So if you see a client that has had sudden weakness, paralysis, or numbness of their face, arm, or leg, on one side, having speech, difficulty speaking or understanding, if they have sudden change in their vision, so double vision, blurry vision, or loss of vision, dizziness, nausea, vomiting, and vertigo. That too can be a symptom of a stroke, and that's very challenging to actually distinguish between, is this a stroke or is it something else? But important to get this worked up right away. And then of course, a sudden severe headache. We call that a thunderclap headache, and with or without loss of consciousness. Those are some stroke symptoms and warning signs. This is a lovely mnemonic that I think we should all remind ourselves of, and it's really a reminder that, you know, how to quickly spot a stroke, how to quickly identify a patient that might be at risk. And it's this mnemonic, be fast. So if you have a client or participant or patient who is having new trouble with balance or dizziness, new blurred vision, or new facial droop, or new weakness in an arm or leg, new speech difficulty, really you have to stop what you're doing and call for an ambulance. Next slide. And the reason for that is the optimal management of an ischemic stroke. For this to happen adequately, we really want to get very powerful blood thinning medications on board with the person within 3 hours. We have a 3 to 4.5 hour window to really get medications on board to help reverse the issues that are going on. And really, we need to call 911. And when the patient is transported to the emergency department or a stroke center, they will have CT or MRI brain imaging. They might get very powerful drugs to reverse this clot or break this clot up. And if that doesn't work, they may even have a very specialized procedure where a wire can go in and extract the clot from the vessel. And this has to be done in a very timely way. Next slide. So unfortunately for folks who do have residual deficit from their stroke, if the treatment didn't happen in time or wasn't completely successful, of these folks, a third experience some level of depression, anxiety, and apathy. And these symptoms might be out of proportion to the actual deficit that the person is experiencing. The deficits and the mental health issues impact their quality of life. They actually negatively impact recovery. So for people that are undergoing aggressive PT or OT, their recovery can be hampered due to mood issues. And of course, people can have persistent weakness, functional impairment, pain, vertigo, balance issues, and speech difficulty. Next slide. So let's follow up with our patient. So after we saw him, we called 911, we stayed on the line, we got him to the nearest ER. He was given clot busting drugs, all of his symptoms resolved, and he was discharged home with some physical therapy. And thankfully, he did not suffer lasting debility and remained independent in his home because we acted quickly. Next slide. Questions for me? Thank you so very much.
Thank you, Dr. Sagel. I know we're running low on time. Dementia and stroke is a pretty large topic. So if you do have any questions for Dr. Sagel, please feel free to type it in the chat. And I know Dr. Sagel can go ahead and answer questions via the chat function as well. Thank you so much, Dr. Sagel. Let's go ahead and move on into our case overview. So let's see, this case will be presented by Deborah. She's a Client Services Coordinator at Service Opportunities for Seniors. Deborah, are you on the line?
I am.
Yes?
Yes, can you hear me?
Yes, I can hear you. Thank you. So while Deborah's giving a quick overview of her case, please think about follow-up questions you may have for her. Think about how you'd handle the case and resources you have at your site to assist this client. Please pull from your experience of working with your Meals on Wheels clients. It's going to be a collaborative discussion. I know we don't have that much time, but let's go ahead and have Deborah give us a quick overview of this case. Let me go ahead and share the case and let's all see. Go ahead.
Okay, so I'm discussing KW, who I contacted for his initial assessment a few months ago. He had contacted us to begin Meals on Wheels during the pandemic, so I had never had a chance to meet him. We're not doing in-home visits these days. When I called him, he let me know that he was a retired lawyer who had been working at the Oakland Coliseum before COVID, but then he had lost that job and now he was living on $180 a month of unemployment. He said he was unable to pay his rent or utilities. He was able to hobble to a corner store to buy food. He had a torn Achilles tendon that wasn't healing, but that was taking all of his money, and he was scared. I threw a bunch of resources at him. He said that he'd be able to make use of them. So we talked about increasing his income, of course, looking into HEAP to pay his utility bills, contacting PG&E to lower his utility bills, applying for food stamps, applying for the Mercy Brown program up here, which is a grocery delivery. He said that he could ride public transportation, but knew that that was a bad idea to do during the pandemic. So I gave him some information about transportation resources. He did mention that he had some forgetfulness from some brain aneurysms that were not operable, but he thought that he could follow through on these referrals, and he had friends who could help him with them. So I sent even more resources through the mail. And he did say that he was talking to his doctor. He could manage his own ADLs and IADLs by himself. And he said that he was going to be okay and thank you for the resources. However, I was concerned about him, so I did check back a week later, and he had not really followed through on any of the resources I gave him. At that point, he acknowledged that his friends actually had stopped dropping by during the pandemic, and that his only family member who was contacting him was his sister in New York City, who wasn't able to really help him much. And he did acknowledge that he wasn't really going to be able to follow through on the referrals because of his cognitive deficits, which he likened to having a stroke. So at that point, especially because we're not able to go out and visit ourselves, I really didn't know how safe he was. I contacted his sister. She agreed that he probably wasn't safe. And so I made a report to APS to jump in. Fortunately, APS is able to go out and visit clients, and they were able to get out there and help him apply for benefits. And last I heard from the family, he was doing much, much better. But I was bringing up this case because I'm curious as to what other people might have done during this, facing a situation like this. And also, if we had been able to see him in person, what kinds of things would you have looked for, and how would you have helped him?
Thank you, Deborah. Let's go ahead and ask everybody on the line. What kind of questions do you have for Deborah, or what would you have done if this was your client?
Deborah, how did he find you guys? How did he get connected to you?
Great question. I don't actually know. I don't have that in my notes. I would guess he was living in an apartment building. He may have had friends nearby who had also received Meals on Wheels. He's actually pretty young. He's only 63 years old. But somebody must have told us about him.
I thought that you did an amazing job with all of the resources you provided him. That was really impressive. It sounds like he's also linked with Kaiser. Is the Kaiser social worker involved?
I don't know, because he couldn't tell me the name of his Kaiser doctor, and I didn't get in touch with Kaiser. I figured at the point I was handing it over to APS, they could do that work. But I would hope, yeah, that the Kaiser social worker was involved.
Okay.
I see Daryl on the line says, seems like it's a double whammy of health and isolation that he's dealing with. Anyone else on the line have any stories or were able to visit him at home? What other resources or steps would you have taken?
I think APS is where I would have gone as well, and hopefully they can connect with the Kaiser team. And very similar to last case we had, Activate Home Health, the home health team that Kaiser also has case managers and social workers to help facilitate these kind of barriers to and social determinants of health factors like transportation that you had mentioned earlier, Deborah. So the good news is it sounds like he's resourceful. He was able to connect with you, and he's partnered with caring people like yourself and APS, and hopefully they'll get connected to the Kaiser Home Health folks that can continue to keep a clinical eye on what's going on with him.
Thank you, Geraldine. It looks like we have two. Daryl and Vicki said that he might appreciate a phone buddy if you guys have that service, or like a friendship line. I know in one of our first sessions, a few Meals on Wheels member agencies have that service to provide them with. I don't know if you do, Deborah.
We do. I was more concerned with his safety at first, but that was a later consideration to hook him up with our friendly visitor program.
Wonderful. And let's see, anything else? Any other suggestions for Deborah? Everyone seems to think that you did a really great job, Deborah, and in the steps that you took actually in the chat as well. Any other suggestions? Anne says, I think you did a great job. Okay, any other questions you have for the group, Deborah?
No, I don't. Thank you, everybody. I appreciate your feedback. And I do feel like I should get back to him and talk to him about the friendly visitor program now that I think things have calmed down a bit for him.
Yeah, wonderful. Thank you so much. And somebody just said, I think using a telefriend or check-in service would be a great way to have additional eyes and ears on the client. So yeah, I think that would be a great next step. Thank you so much for submitting the case. Does anybody have any, I know we had to cut off Dr. Sagel and people from asking her questions, but I know we have a few 2 to 3 minutes if anybody has any last minute questions for Dr. Sagel as well.
Nika, I would like to have Dr. Sagel go into the nutritional component just a little bit more, because I think that for Meals on Wheels providers, that's something that's really interesting. If that falls into something that we should be looking at, how are they using the nutritional support we're providing, et cetera?
Absolutely. So nutrition is so important for everyone, certainly for folks who may be homebound, maybe they're not able to get out, get some sunlight, get adequate exercise. So nutrition is extraordinarily important. As it relates to cognitive impairment, you know, there are certain deficiencies, so in particular vitamin B12 and folic acid, that if low, can actually cause a lot of health problems. They can actually cause cognitive impairment. They can cause neuropathy. Sometimes people start to feel like they're fatigued. And in very severe situations can actually lead to anemia or a low blood count. So those two vitamins in particular are really important. And for folks who are vegetarian, or our main source of vitamin B12 is through animal-based products. So vegetarians and vegans are often B12 deficient and need to supplement with vitamin B12. And then interestingly, something happens as we age. We lose a protein. It's called intrinsic factor. It floats around in our stomach and it grabs the vitamin B12 from the food that we eat. And when this protein goes down, and it naturally diminishes in certain folks, you don't absorb the B12 from your diet. And then or vitamin B12 tablet, but often it doesn't work. It doesn't raise the levels adequately, and we have to go to an IM injection, so an injection of vitamin B12. In the United States, our food sources like cereals and breads are fortified with folic acid, because folic acid is the nutrient when deficient can lead to neural tube defects in pregnant women. And so our food sources are and breads and things like that are fortified with folic acid. But really, so good nutrition, absolutely important on so many levels. And certainly for stroke too, right? So we want to have a diet that's healthy and high in fiber, low in saturated fats and sodium.
Thank you.
Thank you.
Any other questions for Dr. Sagel? Okay, okay, to close out today, if you do want to receive the CEs, please make sure you fill out the link on this form. I'll also send it in the follow-up email that comes at the end of today. And we always love your evaluations. Thank you so much for taking the 3 minutes to fill them out. That's always so helpful to us. We can also suggest topics for future ECHO sessions. And then a CE certificate will arrive via email at the end of the series if you do request CEs. Our fourth session is going to be taking place in 2 weeks on June 4th on changes in conditions, but focusing on elder abuse and neglect. And that's going to be presented by Dr. Lisa Gibbs, who presented our first session, and then Jorge Sole, who is the Assistant Director of the Center of Elder Abuse and Neglect here at UCI. So we're really lucky to have them join us at the next session. Thank you all so much for being here today, and we look forward to seeing you in 2 weeks. Thank you, Dr. Sagal, and thank you, Deborah, again for today's session. Have a wonderful day.
Thank
Thank you,
you.
everybody.
All right, thank you.
Bye.
Great session.
Thanks, everyone.
Thank you.
Bye.